Welcome to Medical Insights Podcast, where we explore detailed clinical case studies in a formal and business-oriented tone. Today we begin our discussion with an in-depth exploration of several significant medical cases from a recent exam portfolio. We examine a case of cerebrovascular accident in a 54-year-old male from a rural background who presented with sudden onset weakness of his right upper and lower limbs. He experienced a deviation of the angle of his mouth to the left, which indicates involvement of the facial nerve. The onset of his symptoms was abrupt and progressed over a few hours as described by his history. His clinical presentation was devoid of accompanying headache or vomiting, which might have suggested alternative diagnoses. The absence of visual disturbances and loss of consciousness further narrowed the differential diagnosis. His family and past medical history did not reveal prior episodes or related comorbidities. The patient had a history of chronic smoking and alcohol consumption that contributed to his risk profile. On examination, his vital signs were stable, and his general physical condition was moderately built and nourished. A detailed evaluation of the central nervous system revealed normal orientation and higher mental functions despite the motor deficits. His evaluation showed clear signs of right-sided hemiparesis, with particular involvement of the upper limb. Additionally, the left facial nerve was affected as evidenced by the deviation of his mouth. His sensory examination remained within normal limits, and no cranial nerve deficits were noted apart from the facial palsy. A focused motor examination documented hypertonia in the affected limbs, along with diminished power and brisk reflexes on the affected side. Ankle clonus was also demonstrable during the neurological assessment. His coordination tests indicated difficulty, particularly with upper limb movements due to weakness. The clinical picture was highly suggestive of a thrombotic cerebrovascular accident involving the left-sided internal capsule affecting the lenticulostriate branch of the middle cerebral artery. The general physical examination did not reveal any dermatological or systemic markers that might have pointed to an underlying infective or inflammatory condition. Furthermore, his cardiovascular and respiratory systems did not present with abnormalities that could complicate the neurological picture. This case underscores the importance of detailed neurologic examination and correlating clinical features with established stroke risk factors. Moving on to the next case, a 46-year-old male worker from a cotton mill presented with complaints of cough, chest pain, and progressive breathlessness over a 2-week period. His respiratory symptoms developed in a gradual and progressive manner without any preceding similar episodes. He noted a dry intermittent cough that was associated with pricking chest pain localized to the right side. The chest pain exacerbated on inspiration, while there were no significant relieving factors. His complaint of breathlessness had gradually worsened over 10 days and interfered with his daily activities. The patient did not experience hemoptysis, nor was there any report of wheezing. His social history revealed a long-standing history of smoking. There was no history of fever, weight loss, or night sweats that might have suggested a systemic illness such as tuberculosis. The patient also did not have any signs of cardiac failure, as there was no significant history of lower limb swelling or orthopnea. On general examination, he appeared dyspnoic and moderately built with no cyanosis or clubbing. His pulse, blood pressure, and respiratory rate were recorded with notable tachypnea. An inspection of his respiratory system showed a deviation of the trachea that was meticulous, and asymmetrical chest movements were noted. On palpation, the chest wall did not show any tenderness, and the tracheal shift was confirmed to the left. The percussion notes were stony dull over parts of the right chest region. Auscultation revealed diminished breath sounds and reduced vocal resonance in the right infraclavicular and inframammary areas. The absence of a succussion splash and the results of coin tests ruled out other pathologies. The clinical findings were conclusive of a right-sided pleural effusion. The probable etiology was considered to be tuberculous in nature. The case emphasized the role of detailed respiratory system examination combined with occupational history to ascertain the cause. Subsequently, we examine another notable case involving a 46-year-old male shopkeeper who presented with cardiac complaints. His symptoms included chest pain, palpitations, exertional dyspnea, and episodes of syncope. He had a history of progressive breathlessness, consistent with a NYHA Class 3 level of severity. In addition, he experienced orthopnea and paroxysmal nocturnal dyspnea. His symptoms of palpitation were episodic and irregular with a transient irregularity in rhythm. His past medical history noted similar cardiac episodes that had been evaluated 4 years earlier. There was no history of diabetes, hypertension, or any infective episodes such as rheumatic fever. He also had a smoking history that placed him at higher risk for valvular heart disease. On examination, his pulse was found to be irregularly irregular, indicating the presence of atrial fibrillation. The physical examination of his cardiovascular system revealed a hyperdynamic apical impulse with a palpable thrill in the mitral area. A parasternal heave was present that indicated left ventricular hypertrophy. Auscultation in the mitral area disclosed a high-pitched soft blowing pansystolic murmur that radiated to the axilla. The absence of murmurs in other areas further consolidated the diagnosis of mitral regurgitation. Additional auscultatory findings in the aortic, tricuspid, and pulmonary areas were within normal limits or demonstrated nonspecific changes. This case demonstrated the classic clinical presentation of acquired valvular heart disease, likely of rheumatic origin. The examination findings correlated with the patient's history of chronic smoking and alcohol consumption. The integration of physical findings with the history allowed for a precise formulation of the diagnosis. As we transition further in our discussion, we now review a complex hepatobiliary case that centered around a middle-aged male with uniform abdominal distension. This 48-year-old male Mason had noticed a progressive increase in abdominal girth over a 15-day period. He reported an associated history of yellowish discoloration of his eyes and dark-colored urine that had persisted for about a month. Despite the jaundice, his stools remained of normal color and he did not experience pruritus. There was no report of abdominal pain or vomiting that might suggest an acute abdomen. His history also did not include any features of gastrointestinal bleeding. The patient had a long-standing history of alcohol abuse, alongside chronic smoking, which predisposed him to liver pathology. On physical examination, he was found to be conscious and oriented, although he displayed signs of jaundice and anemia. He had bilateral pedal edema, and his general examination confirmed the presence of stigmata of chronic liver disease. Markers such as parotid enlargement and a flapping tremor were evident on neurological assessment. His vital signs remained stable despite these findings. The abdominal examination documented a uniformly distended abdomen with full flanks and shiny stretched skin. The umbilicus was displaced downward and presented as a transverse slit without any vascular dilation. On palpation, the liver was not directly palpable, but the spleen was enlarged. Measurements from the xiphisternum to the umbilicus and to the pubic symphysis were abnormal. Percussion confirmed a shrunken liver and an enlarged spleen with shifting dullness demonstrating fluid accumulation. Auscultation over the abdomen revealed normal bowel sounds and the absence of bruits. The comprehensive evaluation established the diagnosis of ascites in the background of cirrhosis of the liver with portal hypertension. The likely cause was identified as alcoholic liver disease in a decompensated state. This case illustrated the importance of systematic abdominal examination in detecting signs of chronic liver dysfunction. It also emphasized the role of detailed history taking regarding alcohol intake and associated systemic signs. The subsequent discussion among the examiners emphasized the necessity of correlating clinical findings with supportive investigations. Notable laboratory markers of liver cell failure were part of the diagnostic criteria. The evaluation also covered related manifestations, such as parotid gland enlargement and flapping tremor, that are crucial for clinical assessment. The speaker highlighted the essential nature of assessing the systemic impact of chronic liver disease. In each of these cases, a methodical approach to history taking and physical examination formed the basis of diagnosis. The integration of patient demographics, risk factors, and clinical signs was paramount to the diagnosis. Each patient's unique presentation provided insights into the complexities of modern medicine. The discussion extended to the importance of utilizing proper examination techniques across neurological, respiratory, cardiovascular, and abdominal systems. Knowledge of specific clinical tests such as tactile localization, coordination tests, and auscultatory findings remains critical. The cases also shed light on the contributory role of social factors like socioeconomic status and occupational exposure. The speaker reiterated that details such as duration of symptoms and the progression of clinical signs provide a framework for diagnosis. An emphasis was placed on the role of non-invasive examination in initial patient evaluation. The need for subsequent confirmatory investigations such as imaging and laboratory studies was also discussed. The speaker explained that early detection and intervention in these cases can prove life-saving. A holistic approach that considers both clinical findings and patient history enhances diagnostic accuracy. The importance of a multidisciplinary team in managing complex cases was also underscored. Each case presented a unique diagnostic challenge that required careful thought and evaluation. The cerebrovascular accident case illustrated the impact of chronic lifestyle factors on vascular health. It was emphasized that timely recognition of stroke symptoms can significantly improve outcomes. The discussion further detailed the necessity for rapid referral and treatment in suspected stroke cases. The respiratory case provided insight into the clinical evaluation of pleural effusion and the use of percussion and auscultation as critical tools. The cardiac case was an opportunity to review valvular heart disease and emphasize the role of regular monitoring in patients with chronic risk factors. The ascites case presented a classic picture of decompensated cirrhosis and the associated systemic manifestations. The speaker elaborated on the significance of correlating physical signs with patient history in synthesizing a final diagnosis. Several key points were reiterated throughout the discourse, such as the importance of methodical evaluation and the avoidance of premature diagnostic closure. The significance of a detailed physical examination and structured history-taking was emphasized repeatedly. The speaker stated that every minute detail in patient evaluation could influence the final outcome. The cases served as an educational tool for aspiring clinicians and highlighted real-life applications of theoretical knowledge. The discussion also included reflections on useful diagnostic techniques that are crucial in everyday practice. The speaker encouraged clinicians to maintain a high level of suspicion in patients with risk factors like smoking and alcohol consumption. The importance of understanding the pathophysiology underlying each condition was elaborated on in detail. Special mention was made of the diagnostic criteria for stroke, pleural effusion, valvular heart disease, and cirrhosis. Detailed analysis of each case allowed for a comprehensive review of clinical signs. The speaker noted that meticulous physical examination can sometimes provide more information than advanced imaging. He stressed that a sound clinical assessment is the cornerstone of effective patient management. Emphasis was placed on patient safety and the minimization of diagnostic errors. The integration of history, examination, and targeted investigations was described as essential for reaching viable conclusions. The speaker also commented on the importance of educating patients regarding lifestyle modifications. Preventative measures in at-risk populations were discussed. The role of patient counseling and effective disease management was highlighted during the discussion. The speaker included insights on the evolving nature of clinical guidelines based on recent medical literature. The discussion also underscored the value of continuous medical education. Next, the speaker pointed out specific examination nuances, including the measurement of chest expansion and the evaluation of heart murmurs. A detailed description of the mitral regurgitation murmur was provided in simple terms. The speaker also differentiated between regurgitant and stenotic lesions in valvular heart disease. An emphasis was placed on the diagnostic importance of auscultatory findings in the cardiac examination. The need to assess jugular venous pressure and peripheral pulses was also discussed. Each physical finding was linked back to the underlying pathophysiology of the disease process. In summary, the integration of laboratory markers with clinical examination was noted as being of utmost importance in each case. The discussion was rich with clinical pearls and practical diagnostic tips. The speaker advised that a structured approach is critical even in busy clinical settings. He observed that clear documentation of findings assists in broader clinical decision-making. The value of peer discussion in challenging cases was also mentioned. The speaker reiterated that thoroughness in clinical evaluation cannot be overemphasized. His detailed review of the 4 cases provided insights that are applicable across various medical specialties. The discussion illustrated how modern medicine relies on both technology and the art of physical examination. He emphasized that despite advances in diagnostic imaging, the clinical exam remains unrivaled in its value. The session also discussed potential pitfalls that can lead to misdiagnosis if the examination is incomplete. The speaker highlighted strategies to avoid cognitive biases during patient evaluation. He stressed the importance of remaining updated with the latest clinical guidelines. The discussion also provided guidance on managing diverse clinical presentations. He encouraged clinicians to be vigilant in recognizing atypical presentations. Detailed case histories were shown to be instrumental in guiding further investigations. The use of structured case reporting was advocated as a tool for clinical learning. The speaker urged that comprehensive documentation contributes to better patient outcomes. He noted that continuous feedback from peers aids in refining diagnostic skills. The speaker also addressed the importance of cross-checking physical findings against patient history. He mentioned that even subtle changes in physical signs should not be overlooked. The discussion emphasized that effectively communicating findings to the patient can enhance compliance. The speaker described how patient education plays a critical role in managing chronic illnesses. He stressed that early intervention based on clinical suspicion can prevent disease progression. The session also reviewed the relevance of occupational history in understanding disease etiology. In concluding his extended discussion, the speaker summarized that these cases exemplify the multifaceted approach required in medical diagnosis. Each case presented unique challenges that reinforced the value of a systematic and thorough evaluation. The speaker affirmed that these clinical scenarios remain cornerstones in medical education and daily practice. He encouraged all clinicians to continually refine their assessment techniques for optimal patient care. Thank you for joining our detailed discussion on these complex medical cases and for trusting in our commitment to clinical excellence. Thank you for listening.